The Worcestershire Integrated Care Programme is called Well Connected. It tries to be like Ron Seal and do what it says on the tin. And I'm in the very privileged position of being employed jointly by the three clinical commissioning groups, the County Council and the two main provider trusts, working across the whole system with social care. So it is a whole system approach. We have focused particularly on older people, people with long-term conditions, complexity, which is one of the elements that, that Bob was talking about. We're not excluding other sections of the population, but our combined collective responsibility. So we've agreed a vision that in Worcestershire by 2020, individuals, families and communities will be supported to take control of their ongoing health and well-being and look after themselves to have as healthy and fulfilling lives as possible. And that everyone will have a proactive care plan where that is appropriate, and the plan will be owned and developed with individuals and their families, and everybody who's working to support them will have been putting into that. And then if people need specialist care, there will be a partnership between the extended primary care team and secondary care, rather than the handoffs that we traditionally have when somebody crosses the threshold of an acute hospital. So very happy to share the kind of more detail behind that. So we have recognised that the current system of organisational boundaries and professional boundaries gets in the way of people having the experience of care that is better for them. So we've got a history of using some flexibilities under Section 75 to integrate some services, some really good experience with mental health and learning disabilities particularly. But we also, a couple of years ago, closed longer-term rehab wards in the acute trust and TUPE'd staff across from both the acute sector and the community into a new rehabilitation unit managed by the County Council. So it was a kind of leap of faith, so it's now CQC registered by the County Council, employing clinical staff who were traditionally employed by the NHS. So part of our plans are predicated on the fact that without the right people with the right skills, we're not going to deliver the right care, but also recognising that every health and social care economy in the country wants to recruit community geriatricians, they want more GPs, they want people who can manage acute stroke, people who can do comprehensive geriatric assessment. So we can't recruit and retain those people quickly, so we have to find ways of providing those skills within the existing workforce as we try and grow a different workforce for the future. So really good relationships with our local university that does most of our pre-reg nursing for nursing therapy and social care. A lot of synergy on the curriculum, but also encouraging them to teach people together so that they learn together, as well as having core curriculum components. Definitely concerns about primary care. There's been in Worcestershire significant reduction in primary care capacity at the time that we're wanting to increase it. So that's one of the, on my worry list rather than solved bits of the conundrum. But we have made significant progress in training and skilling people to provide generic skills across physiotherapy, OT, speech and language therapy and nursing and care things in the community to a kind of level 4 capacity. We haven't got it all sorted. One of the things that Bob mentioned earlier was around language. We use language differently to describe things, and a care plan means something different to an individual, to a GP, to a social worker, to a therapist. So we have to try and agree on the language that we use to describe what we want. I think there's something about challenging some of the status quo. It's not that many years ago that you had to be a doctor to take blood. Now the last person you want taking blood is a doctor. What you want is one of those nice phlebotomist people, because they're going to be an awful lot better at it. So there's something about when people say you can't, trying to say, okay, so what would enable us to be able to do things differently? And picking up some of the stuff that Bob said about leadership, we are working towards much greater partnership between our component organisations, and one of the bits of support for us as a pioneer is some leadership development capacity through Public Health England and the Systems Leadership Academy. So we're trying to make the best of the workforce we've got now. The people that work in Worcestershire are the people we're going to continue to need to work in Worcestershire, but where they work and how they work needs to change. Okay, happy to stop. I've now lost you.
Thank you. Thank you. Yeah, I'm sorry, I'm back. and we have your slide on screen. So let us just turn for clarifying questions, and we'll just take it in turn again. I'm going to start with Joe, and then I'm going to come to Bob, and then Sanjeev.
Gosh, I suppose I've got so absorbed. There are so many similarities. So I suppose it's around your post. You certainly, the recruitment of your post seems to certainly be a very sort of a joint post that covers a number of organisations. Can you tell me a little bit about the history of that recruitment process, I suppose?
Okay. Shall I take all of them and then come back to them, Matthew?
Sorry, yes, you're quite right. Bob.
Yeah, thank you for your presentation, and there's a lot there. Joe's right, and I would be interested in hearing a little bit more, not necessarily by way of clarification, but just your views on how care centred around a GP practice can be best delivered with a multidisciplinary team that might have a tendency to have a hospital focus traditionally, but we want to get them outside of the walls of the hospital, working with the voluntary sector in the community. So just interested a little bit more on centred around GP in the community.
Thank you, Bob. And Sanjeev?
Yes, I was interested to hear about your focus on the existing workforce, and I'd be interested in a bit more detail about how you are working to support the development of the existing workforce into new roles, and also how your LETB is supporting you in that journey as well.
Okay.
Thank you. Francis, 3 good questions there.
Okay. Right. Start with Joe. Yeah, my post. The integrated care program really grew out of an acute services review that says in order to have sustainable acute services, it was no longer possible to recruit the right number of people and to maintain them on different sites, and therefore we need to shrink the acute footprint and reorder where things are. So much more care needs to be happening in the community, and that's really where this cohesion came from. I think it's an enormous privilege to be where I am because I don't have any organisational allegiance. So I'm employed to look after the best interests of the just under 600,000 people in Worcestershire. I report to each of the boards, to all of the chief executives, and to kind of publicly accountable to the people of Worcestershire. My personal history is that I've never directly worked with social services until now, and not had such strong relationships with the voluntary community sector as we do, because they're one of our formal partners through Age UK. But I've worked in every bit of the NHS, so I've got the badges in terms of something about some credibility of understanding some of the challenge. So it's not perfect, but it really does help, I think, in terms of challenging some of the things to say, is this right for the people of Worcestershire, or is this right for an individual organisation?
Mm-hmm. Thank you. I'd love to ask another question, but I'll wait my turn.
Okay. Bob, general practice is the bit of the NHS and the social care system that the public tell us they know, love, trust and understand more than anything else. The public aren't very interested in CCGs, in trusts, in the TDA, Monitor, NHS England and all the other bits that we carve ourselves into. And I think there is something about trust and confidence of the family doctor, but we know that the breadth of work and care is not confined to medicine. So we've got some very natural communities, so there isn't a kind of one size fits all. You were talking about the size of your hubs. We have some practices that very naturally group together into something that is a cohesive community, and therefore they can do more sharing of staff across teams. But there are a couple of places where it is a single practice with the team based around that and providing that care and support. We're also working, as I say, with Age UK and other voluntary and community sector organisations, and I think have been very inspired by some of the work in Staffordshire from the No-Still project, but also from Cornwall with the Newquay project, about recruiting people who come with the badge saying, I've come from the doctors to help and support you in a very non-clinical way, particularly supporting carers to be able to continue to provide that vital support function. So there's something about using the absolute strength of general practice. One of the key enablers for us is that all of our practices, we've got 66 practices in Worcestershire, and they've all moved to the same IT system. So there's something about being able to share wherever people appear in the system and changing some of that in out of hours care. But the kind of the confidence that the public have in general practice.
Francis, just to push you on this, I think Bob was getting at if when you build these teams around the GP practice, if you've taken the team out of the hospital, how do you take the hospital out of the team?
Yeah, and it is an issue. Everybody who works in the community will at some point have worked in hospital, or most people, lots of people in hospital have never worked in the community, and I think that change in emphasis of being a guest in someone else's home, and we know that people's tolerance of risk is very different in hospital. Once you cross the threshold, there is a different governance and risk in terms of how independent and the kind of environment in which they're living. So we've worked really hard on developing partnerships between secondary care colleagues and community primary care general practice colleagues to build those relationships where people understand each other more and can happily discuss over the telephone and share a care plan and the development, rather than having to be referred and the patient carers needing to travel.
Yeah,
thank you. And Sanji's question in relation to professional development and the LEP-B and so on.
Okay, the LEP-B, as I say, I think initially people were a bit surprised about who we were and what we're trying to do. So I've got a very able medical director colleague who works with me part-time. She only works a day and a half a week. And there's something about the LEP-B, I think they've been a bit behind the curve in terms of understanding why integration that doesn't fit into a nice, neat trust or CCG pot and actually looking at this whole system needs. But having got into the LEP-B and the LET-C, they're now very supportive, and they've actually supported some development funding for us to do some of the scoping about our needs for the future in partnership with some of the specifics around urgent care, which is obviously one of the key elements that we need to improve. So there's something about, again, being pretty pushy about making the relationships, because people don't necessarily appreciate what it is that we're trying to do if we don't go and help them to understand it. So once we've done that, being incredibly supportive, once we get on the radar.
Thank you. Okay, I'm going to go back to colleagues, and unless you've got a burning further clarification question, let's have some of your feedback. What struck you as kind of clear strengths? And can you provide any help or suggestions for Francis? And I'm going to go to Joe, and then Sanjeev, and then Bob.
So I suppose for me it really sounded like a very grounded methodology, sort of systematic approach, and particularly the sort of the whole system approach that you're developing. And I suppose. I'm still, in terms of, I suppose, understand. It sounds particularly like you really have achieved a huge sense of unified vision, actually, across a number of major stakeholders within your environment. Stakeholders that may have different priorities, some of whom may be slower to come to the shared vision, may have sort of a different pressures. And I suppose for me that felt like a real key to your success. Embodied in your joint leadership role. I think that it sounded like that development of relationship was particularly evolved. And I suppose in terms of challenge, I would say that we feel that we're probably on the similar sort of route at the moment, but it's how you really begin to develop that shared vision, not only within the sort of higher echelons of our organisational groups, but really how you develop that sort of distributed leadership and have that common voice and vision through our entire workforce, how we really impregnate that in a meaningful way, I think is a huge challenge for us all.
Yeah, absolutely.
Thank you, Joe. Sanjeev?
I concur with Joe. I mean, I think the way you're approaching it through the whole system is actually fabulous. I also applaud the sort of the recognition of the need to invest in your established existing workforce and help them move along the journey that I think you're undertaking. Is great to hear. I think there are some challenges that I hear. One of them is around the notion of the primary care and the capacity issues that you've got, and I think that's one that I think we all have in common, really. The second one is this idea that you need to carry on challenging traditional stereotypes, because if you don't do that, then I think we don't shift and move in the same direction. So I think that's an ongoing challenge that I recognise certainly in my patch as well.
Thank you.
Thank you, Sanjeev. And Bob.
Yes, Francis. Thank you for your thoughts there. I would also congratulate what you're doing. It's really encouraging to hear that. And there's two things that really particularly interested me. One is this idea of a single joined-up GP ICT system, which if we could get to the point where that's integrated with hospital and community team records, and indeed the person in their own home having access to that, I think that's going to be a key enabler. The other thing that I was interested in terms of your concept of a multidisciplinary team working around GP practice is around how we engage hospital teams in the community, and I like yourself have some good experience of how that can work well. And I worked with a diabetes consultant in Northern Ireland, and there's one here in Torbay who I think diabetes we can all learn from, because it's largely a primary care condition. GPs manage with practice nurses diabetes very well, but when a person has comorbidities and complexity, you can do a lot more close to the GP practice if we can get the traditional hospital team out working in the community with those people.
Absolutely.
Thank you. Thank you, Bob. If I were to add two things, I'm particularly struck by your focus on having to change the existing workforce rather than recruit and grow a new workforce. And so one question I have really is around values. How do you begin to shape and change the values that existing workforce bring to their work in relation to the values in the way they view other organisations and colleagues in other teams, but also how they view patients and carers and the roles that patients and carers are being asked to play, and the relationships that we want staff to develop with patients and carers. So how do you change the values of the workforce over time? And I was particularly struck by what you said about when people say you can't, and in particular the sort of behaviours around protecting existing roles. And we should recognise that actually people's careers and people's job plans and their promotions are not necessarily aligned with an integrated care model. So how do you begin to change the sort of professional trajectories and the career plans and job plans of healthcare professionals so that actually integrated care will work for them rather than the status quo?
Yeah. Yeah, I agree. Absolutely critical. Really helpful feedback from all of you. Thank you. If I just pick up a couple of things, I think, Bob, in terms of the ICT, technology is an enabler. It's not the solution. But one of the things that was a really powerful kind of game changer was when the IT group was led by my medical director, Dr. Bernie Gregory, rather than by the IT people. Mm-hmm. So if you put IT people in charge of joining up to IT, they'll go for a perfect system, and there will always be a more perfect system around the corner. So actually this is about being clinically led and saying, actually, the way I can change, I can provide better care and to facilitate my practice, this is what you guys need to deliver for me. And that was a really important change in the emphasis. So actually she's kind of passed it back to one of the clever people in terms of saying, okay, we've now got the agreed strategy, you guys get on and deliver it. But it was really making it, how is this going to make a difference to people's experience of care, not what is a perfect IT system, because it was called Connecting for Health and it didn't quite get us where we need to. And yeah, Matthew, I think there is something about making sure that we use leaders in the system who are able to challenge some of the status quo and are less protective about either not wanting change because they're going soon or because they're not confident about it. And some of our most dynamic new leaders are GPs who are earlier in their careers and saying, actually, you know, general practice will need to change and you need to allow us to get on and change it now, because actually it is not sustainable in the kind of mode